Recording.
Great. All right. So today we're going to talk about bronchoscopy. Some of this will probably have been touched on at the boot camp, but we'll review some of the material, particularly in how you approach a patient for bronchoscopy and get set up. A lot of it can be focused on the thought process related to preparing a patient for procedure. So before we get started, just a quick update. You guys probably saw the email from Pauline earlier this week. We've made some updates to the fellowship manual regarding the UH pulmonary procedure service. That's not really as relevant for you guys until next year. But for the second and third years, please take a look at this stuff. Tried to lay out a little bit more specifically what the roles and responsibilities of the procedure fellow are. Probably most significantly, there's now a pager for the procedure fellow, 37314. We're going to treat it like the consult pager, so just forward it amongst yourselves. This is going to be the primary point of contact for any pulmonary procedure, particularly coming from the endoscopy lab. If they want to get a hold of somebody, this is the way to do it. As such, this needs to be sort of manned 24/7 because people have issues with procedures or post-procedure care after hours, and they will be directed to this pager as the first point of contact. So on the weekends, please forward it to the UH consult fellow so that somebody's available to answer. Chances are there's not going to be a lot of calls, but just in case. All right, so for today's talk, what are we hoping to cover here? Primarily indications, risk benefits, limitations and complications of bronchoscopy, learn how to prepare a patient, and then we'll, depending on time, sort of review bronchial anatomy and radiography with that. This talk has already been uploaded to the Google Drive. Hopefully all of you have access to it. I'm still working on getting the talks from CCF for the boot camp uploaded. The wonderful new security features everybody introduced last year has made trying to share stuff very, very difficult. Hopefully those will be up soon. In addition to this talk, there's also, I'm not sure when we're going to get to it, so it's already up there, but last year's talk on basic sampling techniques is there. It's a good overview of things like transbronchial biopsies, BAL, brushing, that sort of thing. So go ahead and take a look at that as well. So when we talk about bronchoscopy, I like to start, especially if you've not really been exposed before, to the history of bronchoscopy, because I think understanding the history of the development of the bronchoscope and where it came from helps you understand where we are now, gives you a sense for what you can do with it, what are the limitations of the technique and of the tools. And really, the bronchoscopy basically started in 1897 with Gustav Hilling. He's considered the father of bronchoscopy. And he was a physician in Germany, and he had, sort of several technological advances that really influenced the field of endoscopy. In 1897, he took a rigid esophagoscope and used it in the airway for the first time. So this is the first time that any endoscopy instrument had been put into the lower airway, basically through the vocal cords. Upper airway endoscopy has been going on for 30 years at this point. But this is the first time they went into the lower respiratory tract. And the first patient he used it on was a farmer who had aspirated a pork bone. And he used the rigid esophagoscope in the trachea to remove the pork bone, which was a significant advancement in ability to treat people. Aspirated foreign bodies and aspiration in general was this, well, maybe not necessarily common, but it was a very significant cause of morbidity and mortality, 100 years ago or more. These would lead to chronic lung infections and basically, could turn somebody into a respiratory cripple, if not, kill them from the complications of the infection. So this was a remarkable change, and it really ushered in the era of airway endoscopy. building off of that, was Chevalier Jackson, who was an ENT physician in Philadelphia in the early part of the 20th century. He learned rigid bronchoscopy from Dr. Killian and became a great sort of speaker, teacher, expander of the field. He taught lots of trainees the techniques. He did a lot to sort of popularize it here in the U.S. He also did a lot to develop the tools, and the picture here is of him working in his own metal shop in his house, and he would make his own instruments, and he's credited with developing several significant advancements in the technique that made it easier. One of the things he pioneered was the use of distal illumination of the bronchoscope, getting a light source to the distal tip, as opposed to trying to use mirrors and things to shine down from the far end and try to see what's down there. On the left there is actually this suspension laryngoscope. That is basically what it still looks like today. I was in the OR last week with ENT when they were using one. Like it is still how we do things. And then, for about 50 years, 60 years, the rigid bronchoscope was the only way to do procedures in the lower airway. And so naturally, basically it's a big steel pipe. And so it has some limitations, and it's difficult to use, and it sort of limits what you can do based on the fact that it doesn't turn and the airway does. And it's uncomfortable, and a variety of reasons. It was primarily limited to thoracic surgeons. And that all changed in 1966 with Dr. Ikeda, who was a thoracic surgeon, but he designed the first flexible fiber optic bronchoscope. And starting around then, that's when bronchoscopy as a field really took off, because it allowed lots more people to do it. It allowed you to get to areas you couldn't before. You could see things, and shortly after they designed the original one, they added things like a working channel, so you could put tools through and take samples. And over the next really 50 years, there's a huge explosion in the number of things that we're able to do. So 6 years later, this is Dr. Anderson. He did the first transbronchial lung biopsy, so first really non-surgical endoscopic-based lung biopsy. And if you notice, this is a radiograph. They're using a rigid bronchoscope to do this. Now, fortunately, shortly thereafter, they adapted this technique and the flexible forceps to use through a flexible bronchoscope, but the idea here is you could put forceps down from the inside, take a sample, and learn something about what's happening in the lung. A couple years after that, this is Ko-Pen Wong, considered one of the really most important figures in modern bronchoscopy, and again, taught a lot of people how to do this at Johns Hopkins, and is really credited with the development of the flexible needle and transbronchial needle aspiration. Again, allowing much more effective sampling of various pulmonary lesions. And that's kind of where things stayed for about another 20-some years, a little over 20 years. And then in the late 90s, there was interest in developing the ultrasound applications in GI and cardiology were then applied to the airway with some modification. And in 2003, Olympus and Dr. Yasufuku, again, another thoracic surgeon, but developed the linear endobronchial ultrasound scope. And this has really revolutionized our approach to cancer care and really diagnostics in the chest over the last 20 years. Being able to actually see what you're sticking a needle in is a big change from how we used to do it, which was to say, it should be about there, put a needle in, especially when you consider there's lots of large blood vessels running through the center of the chest. This timeline, I think, does a nice job of sort of illustrating the fact that the pace of development in airway endoscopy has really taken off, and you know, starting here in 1800, you've got, you know, light conductors and a glotoscope, and then you have Gustav Killian in the late 1800s, Chevalier Jackson, and then here's where the flexible bronchoscope comes in, and you can see all the things that have happened since then, and you know, both developments in both diagnostic and therapeutic bronchoscopy have really, you know, sort of taken a significant leap during the last 70 years. So back to doing a bronchoscopy. Every time you're approaching a patient with a procedure, you know, there's a series of questions that you have to ask. You know, why do we need to do it? Can I do it? And again, why do we need to do it? What's the indication? What am I trying to accomplish here? If I don't have an indication, you know, or a good indication, I shouldn't be doing the procedure. So you need to know what you're trying to do, what you're trying to achieve. May I do it? Do you have credentials to do it? Does the hospital allow you to do it? And just for the record, second and third years, you are not allowed to do bronchoscopy by yourself. You are not credentialed to do that. The fellowship manual sort of states that. We say, look, you're not quite ready. We will sign you off on other procedures like central lines and whatnot, but bronchoscopy, you always have to have a credentialed attending present with you when you do it. Consent. Does the patient allow you to do it? If the patient says no, and you do it anyway, that's assault. Don't go there. Can I do it? Do I have the knowledge, the skill base, the equipment, the support? You know, there's a lot that goes in here. And if you don't have some of these things, like, you know, limited equipment, or your scope just broke and is out, obviously you're not going to be doing the procedure. And then, can I manage disasters? And one of the things that I always try to have in mind when I'm approaching a patient for a procedure is, you know, what's my plan for when things go wrong? Because they go wrong. And can I anticipate where the complications are going to come from? Because then I can make adjustments ahead of time to try to avoid them. And what am I going to do if they happen? I need to be prepared. I need to know what the fallout is, how significant is it, how prepared am I? For every patient I do a bronch on who has a pneumonectomy, chest tube is sitting right there. Just because the consequences of a pneumothorax in that patient are significant, and I don't want to be searching for a chest tube as they're spiraling downwards. So again, think about, you know, what are the complications, what are the contraindications? Is there something about this patient that says maybe I shouldn't do that? If they got an MI last week, maybe I don't want to be doing this right now. Sometimes I have to, and that's a decision you have to make on a case-by-case basis. You know, what are the factors that are going to, you know, set you up for problems, and how are you going to deal with it? And then finally, can I document it? You got to be able to report it. You know, doing a procedure, especially a diagnostic procedure, if you can't report out what you found, it doesn't help anybody. So pre-bronch preparation, again, indication. Come up with an appropriate indication. Why do you want to do this procedure? What are you hoping to learn? And you know, that really starts with knowing the patient and reviewing the clinical data. You always want to look at the chest imaging. You know, basically the imaging you're working off of now, but have an understanding of what the prior imaging looks like. You know, if something hasn't changed, you maybe don't need to do this. In the ICU, you're probably going to do some bronchoscopies just based off of you know, chest X-rays and, you know, looking for infiltrates and trying to get infectious type sampling. But for most intents and purposes, any procedure we're doing as an outpatient, you're always going to have a CAT scan. So make sure you actually have that. Make sure you've looked at it. You want to review the imaging. You know, again, what you're trying to achieve with this procedure, how you're going to do that. Has the patient had a prior bronchoscopy? That's important. You know, what did they find before? You know, are you going back because something didn't work right the first time? Well, why didn't it work right? If you try to do the same thing, are you going to get, you may end up with the same outcome. What are you going to do differently this time? When you're using moderate sedation, which we're doing less and less, how much medication do they need? Are they somebody that you gave 2 Versed to and they stopped breathing? Again, these are the things you want to know. Or is it somebody who needed 10 Versed just to stop talking? And again, you can learn a lot by looking back and seeing what happened before. Allergies, so they have allergies to anything you're likely to use. Pertinent medical history, and things that are going to impact how you do the procedure, potential risk for complications, uremia, kidney disease, that's going to predispose you to bleeding complications, pulmonary hypertension. Those patients are a nightmare to do bronchoscopies too. You have second thoughts about whether or not you need to do it. Liver disease, again, bleeding complications are the main thing, but you can run into issues with sedation there as well. But again, look at the history, understand how it's going to impact what you're trying to do, and then informed consent. You got to get the patient's permission to do this. And to do that, you have to have a discussion with them or their proxy and say, look, this is what we intend to do. These are the goals of the procedure. These are the limitations, and basically say, look, we're going to try to get our answers here, but here's the likelihood that we're going to be able to achieve this. If you're trying to biopsy a peripheral lung nodule, the yield in the literature is about 70% with advanced techniques. It's not a guarantee, and so you want your patients to understand that because there are alternatives, and you need to explain well, why are you doing this as opposed to say a transthoracic needle biopsy, which may have a diagnostic yield of 90%. Why are you choosing one versus the other? There's good reasons to do that, but the patient needs to understand that. Again, other alternatives, there's various ways to go about things. So, discussing the potential for surgical biopsy, transthoracic needle biopsy, what other techniques could you use? And then finally, complications. What are the potential complications? Talk more about that. Every procedure has the potential for something to go wrong. So trying to say everything is, you don't want to tell a patient that it's perfectly safe, but you want to be realistic and say, look, the likelihood of complications here is low. Bronchoscopy on the whole is very safe. We'll get into this a little bit more later. Just sort of be upfront with them and tell them what they can likely expect. Everybody you do bronchoscopy to, they're going to cough afterwards. Just tell them that up front. They may cough up some blood. They may have a low-grade fever. Just again, the sort of things that are likely to happen, and that way they're not surprised when they do happen. Appropriate pre-procedure tests. Labs, imaging, EKG. This is really on a case-by-case basis. Labs. What kind of labs do you need? If you're going to be doing invasive sampling, you generally want to know, what's the platelet count, what's the renal function. If you're going to give sedation, you want to know those things because that will impact how they tolerate it. If they're uremic or renal failure, your sedation is going to last a lot longer. So if you're using anesthesia has their own requirements. Those are oftentimes varied by the institution. Our anesthesia colleagues, their protocol, as the hospital policy, is that they need labs within 30 days, a CBC and a basic metabolic panel. Okay, so fine, we get the CBC and BMP on everybody who has anesthesia. Do you need to do that necessarily if they're getting moderate sedation? Not necessarily, unless clinically you have suspicion that something may have changed. If there's somebody with kidney disease, you may, again, want to know that their kidneys haven't changed in the, 3 months since their last visit to their PCP and their lab work. If they've got some sort of hematologic malignancy, do you want to know what their platelet count is? Yes. You need to kind of check up on these things. Imaging. Do you have the appropriate imaging? Do you need any new imaging for the procedure you're proposing? Are you seeing somebody because somebody realized 6 months ago they had a lung nodule? Well, what's it look like now? Is it still there? gotten bigger? Are there now lymph nodes? So you may need to get new imaging to be able to do your procedure. EKG, again, patient specific. If they're older, if they have risk factors for cardiovascular disease, probably not a bad idea, especially if you're doing anesthesia, to have a pre-procedure EKG, or at least access to old ones so that they can compare to their physician. And then the plan. How are you actually going to do the procedure? What are you going to give for medication? What equipment do you need? Make sure you have it all. This is sort of day of. What kind of anesthesia are you going to use? What pathology and samples are you going to collect? And this comes back to, again, what are you trying to achieve? But based on the goals of your procedure, what sort of samples do you need, and then what tools, needle, forceps, VAL, what are you going to use to get those samples so that you can run all of the testing on it? And then once you've collected those samples, how are you going to test them? Because if you get a VAL, you can order everything under the sun. Do you need it all? What specifically do you need for this patient? And then post-bronchoscopy care. After the procedure, they're still under the effects of some sort of sedation. How are you going to care for them? How are you going to monitor them? What are you looking for as far as complications? When is it safe to let them leave and go home? Because most of these are outpatient procedures, and the anticipation is they're going to leave afterwards. So, indications. Dr. Mehta, who unfortunately you guys did not get to meet at the boot camp, but I think he did one of the talks. So once that ever gets up online, I get a chance to see him. Is another figure considered to be one of the fathers of modern bronchoscopy, and is probably my favorite or most quotable bronchoscopy enthusiast, as I like to refer to him. But one of his favorite sayings is, "There's no lung disease a little flexible bronchoscope can't diagnose, palliate, or cure." There's a lot you can do with it. So the indications are very, very broad. I like to throw in there make worse, because again, this is why you can't do bronchoscopy on your own yet. There are times when putting a scope down there is only going to cause trouble, and that's what we want to help you avoid. So indications: unusual cough. Is a regular cough an indication? Generally, no. I mean, there are some people maybe, but in general, no. Wheezing, particularly unilateral wheezing. Abnormal chest imaging. Diaphragm paralysis may be an indication. Usually, you're going to get additional imaging and try to figure out why, but you may have to do that. Vocal cord abnormalities. Thermal injury to the lung. Hopefully, you don't see too many of those. Chest trauma. Airway inspection in chest trauma. Certain infections, lung cancer, masses, post-intubation complications, foreign body, and the original indication for bronchoscopy. Stenosis, and then there's a lot of research indications. Bronchs for abnormal chest imaging. Again, this can be things like mass lesions, recurrent infiltrates that don't go away, persistent atelectasis. Pneumothorax, particularly more for a therapeutic indication. Unilateral hyperinflation can suggest sort of a ball valve effect, whether it's a foreign body or a tumor. Adenopathy. Pleural effusions, generally not an indication, but if the lung won't expand, you can sometimes see a secondary effusion, and so looking for a central obstruction can be indicated. Paratracheal masses, diffuse parenchymal lung disease, and again, diffuse parenchymal lung disease, really differentiate between immunocompetent and immunocompromised patients, because how you're going to approach them is different. What you're looking for is different. So contraindications, and this is again where I like to quote Dr. Mehta, but the best bronchoscopists know when not to do a procedure. And that's, again, something that sort of comes with experience, but there are times when you really just shouldn't do it. So there's very few absolute contraindications, and that basically comes down to the patient says no. patient says no or is not able to, cooperate with you, you shouldn't do this. And then sort of technical things like you don't have the experience to do what you're doing, you don't have the proper equipment, you don't have, a suitable area to do it in. Those are sort of technical. But from a patient standpoint, if they say no, that's the end of it. Then there's a bunch of relative contraindications. So severe hypoxemia. Every time you do a bronchoscopy, you're going to make somebody's oxygenation worse. That's a given. If they're already on 100% and 15 of PEEP and nitric oxide, maybe not somebody you want to do a bronchoscopy. So think about waiting. Acute coronary syndrome. So recent MI, unstable angina. Generally, this should be addressed first. Again, there are rare instances where you may have to do something, but you want to think long and hard before doing it. Uncontrolled arrhythmias. Again, get that under control before you do something. Pulmonary hypertension. Be very careful with those patients. They tend to have lots of trouble both with the anesthetic and the hemodynamic complications from that, and biopsying patients with pulmonary hypertension, they bleed a lot, so you need to be prepared for that. Again, think long and hard about whether you really need to do it. Then again, sort of inadequate support. So taking samples that you can't do anything with just doesn't make a whole lot of sense. So high-risk patients, those who can't cooperate, especially if even if you get consent from, say, a family member, if they're not competent to make decisions, if they're not able to cooperate with you, think again about using moderate sedation. You may need more assistance. You may need a general to be able to safely do it if it has to be done. Recent cardiac ischemia or arrhythmias, careful with tracheal obstruction. Again, tracheal obstruction, if you put a scope in, you need to be very careful that you don't. You can take a partial obstruction and make it a complete obstruction through bleeding, swelling, other things that you do with the scope. So you need to be prepared to deal with that. This is again why we say be very cautious about this, because you don't want to make somebody worse. Asthma and COPD, these patients, especially the asthmatics, can end up with bronchospasm as a result of the procedure. Complications. Somebody's already in respiratory failure. Lung abscess, be careful about. If you're not careful, you can open an abscess into the airway, at which point you soil the airway. If you're trying to do this under moderate, their oxygenation goes to shit because their gas exchange is just, you can induce ARDS by soiling the rest of the lung. So you need to be very cautious about going into doing something with a lung abscess. SVC syndrome and laryngeal edema. Again, the potential for completely occluding the airway through additional swelling, so you just need to be prepared in how you approach it. Not that it's a complete contraindication, but you want to have your plan for what you're going to do. And then every therapeutic bronchoscopy, by definition, is high risk. The complication rate is 4 to 5 times what you would see in a standard diagnostic bronchoscopy. So although it's still low in general, it is much higher than a diagnostic procedure. So complications. You probably know Dr. Johnson. The rest of you will maybe get a chance to meet him at some point. Just for the record, he is a pulmonologist by training, so even though he practices in ID now, he knows what he's talking about. And one of my favorite quotes he said in passing when I was very early in training is that bronchoscopy is a contact sport, and complications will happen. So again, we go to great lengths to try to prevent them, but you do things and there's going to be complications. Overall, when I talk to patients, I say that the risk of complications from a diagnostic bronchoscopy is about 1%, 1 to 2% maybe. Most of those are sort of self-limited things. So coughing up some blood, sore throat. The severe complications, the rate of that is actually very low, and in some of these major retrospective analyses, severe complications, which would be massive hemoptysis, laryngospasm, arrhythmias, pneumo, airway obstruction, is about half of 1%. So very rare. Mortality rate was about 0.01%, so 1 in 1,000. Actually 1 in 10,000, exactly. So again, very, very low, but not zero. That's the key. These things happen. And so when again, getting back to how do you consent a patient, when I consent a patient, my spiel, I say the word death as a potential outcome. I tell them that it's very rare, but every time I consent somebody, I say the word death, because unfortunately, I've had patients die. It happens. You do enough of this, especially if you're doing complicated things, you're going to have something not go the way you want it to, and the outcome may not be something, depending on how sick they are, that you can dig them out of. So it's, again, not that you want to emphasize it, but it's important for them to hear that this is not a, completely, this is not getting an EKG, this is an invasive procedure and it carries risk with it. Overall, sort of rates of complication, medication related, sort of variable. Again, cardiovascular compromise and maybe about half of 1%. Death, again, very low, about 1 in 10,000. Hypoxemia, everybody gets hypoxemia. How long it lasts, that varies, but everybody gets hypoxia during the procedure. Pneumothorax rate, really somewhat technical, depending on the location of the lesion, the patient's emphysema, sampling technique, all of those influence it. But in general, it's probably 1 to 2% in certain locations, and with certain techniques, it's been reported to be up to about 4%, but still relatively low. Bleeding varies, and again, largely that depends on the way you define bleeding with a bronchoscopy. Significant bleeding, though, again, is very low, it's about half of 1%. Infection, I'm always suspect of this number. It's quoted at 6%. Not sure I've ever seen an infectious complication related to a bronchoscopy. Again, how do you define that? There's been a lot of attention in the last several years about scopes being able to transmit infections, especially in the GI world. That was a problem with certain scopes, but it's been part of the push to move to disposable scopes in certain settings. Air embolism, again, it's been reported, very rare. So complications. Can you guys, what do we got here? What kind of pneumothorax? Tension, why? Exactly, good. So you've got a large pneumo, but the key here is that this patient's exhibiting tension physiology. You can see the shift, contralateral shift of the mediastinum. So has this happened with bronchoscopy? Absolutely. Anything. Yeah, so even just putting the scope in the airway, the changes in thoracic pressure, if they've got a bullae or something that's a weakened area, if they cough, they can cough it. I think a lot of people who have done this for a while have had cases where all you did was a BAL or all you did was an airway and they got a pneumo. They shouldn't, but it happens. And so just putting the scope down and the increase in your airway pressures can lead, especially with the coughing that you tend to induce during the procedure. So that's a great question. There's different viewpoints on how to do that. Some people will do that if they're doing biopsies. They routinely get one. I tend to be on the other end of the spectrum. I don't get chest x-rays on anybody unless I have a suspicion for a problem or if they have issues during recovery. Just because the likelihood of finding a pneumothorax in somebody who's asymptomatic is exceedingly low. they develop chest pain or they're hypoxemic for a while after the procedure and look to be uncomfortable, then absolutely I get one. But I don't routinely. So I do a lot of biopsies without a chest X-ray. Other people have different practice patterns. The literature is a little bit mixed on, there's not great support for the practice, but nobody's really come out and said you don't need one to do so. So again, getting to the idea of respiratory mechanics and what the bronchoscope does to that in a non-intubated patient with a sort of standard size diagnostic bronchoscope, in this case 5.7 outer diameter, and in the trachea of an adult that occupies about 10% of the airway lumen. At the cricoid ring, which is the narrowest point in the lower airway, is 15%. It's not taking up a large amount if you're not using an advanced airway. If you're using an ET tube, the flexible bronchoscope will, if you're using a 902 tube, which is a big tube, your 40% of your lumen is obstructed by the scope. If you go down to a 702 tube, you're now obstructing 2/3 of it, and at this point, you mostly can't ventilate. And so when you're doing bronchoscopy, especially in the ICU, you have to take into account what size ET tube do they have, because that's going to influence what scope you can use. And if you need to do something with a larger scope, then you need to think about, do I need to upsize my tube? And again, things that you need to kind of pay attention to as you approach somebody that you're going to do a bronch on. And if you're working with me in the ICU, if we're going to do a bronch on a patient, the first question I ask is, what size tube do they have? Because that influences, again, which scope I can use. Can I get away with a smaller scope, or do I need to upsize? And just for reference, these are we pretty much converted over all to the 190 series of Olympus bronchoscopes, and these are the outer diameters of each of the scopes. So the therapeutic scope, the TH190 is the 6.2 outer diameter, a decent sized scope. It's not our biggest. The EBIS scope is actually 6.9. That is the biggest scope we have. And in general, I want 1.5 millimeters of additional internal lumen. So endotracheal tubes are sized based on internal diameter. So if I'm using, if I'm going to do an EBIS, I want a minimum of an 8.5 ET tube, because otherwise I just don't have the space to, one, maneuver the scope, make it risk damaging the scope, but more importantly, I'm going to have trouble ventilating and oxygenating the patient. So again, more effects of the scope on the airway pressures. You induce auto peak. And again, the bigger the tube, the less you do this, but you put a standard scope through an 8.0 ET tube, auto peak will generally remain below 20, but if you're trying to put it through a 7, if you're using a ventilator, it's going to have to really jack the pressure to maintain ventilation. Auto peak can reach 35 centimeters of water. That's really hot. This is why you can do nothing in the airway and still end up with a pneumothorax, just because of the shifts in pressure. You'll see a little bit of this with somebody who's spontaneously breathing. You'll get some auto peak just from the scope, but it's probably on the order of more like 6-7 centimeters of water. What else? This auto peak increases FRC, decreases FEV1, so you're going to have issues with gas exchange. Bronchoscopy will drop your PaO2 about 10 to 20 millimeters of mercury. This is an uncompromised sort of normal patient. The other thing to keep in mind is that every time you suction, you're sucking up. Every 1 second compression of your suction is 200 to 300 mLs of volume. If that's what their tidal volume is, you're sucking up all of their ventilation. So by far the biggest reason for hypoxemia, especially in a moderate sedation case, is too much suction by the bronchoscopist. So, be cautious of how many times you press the button and suction it up. PCO2 also increases during bronchoscopy by an average of about 8 millimeters of mercury. BAL, because you're flooding a part of the lung, predictably causes declines in oxygenation. And then post-procedure, a normal patient, someone without lung disease, their gas exchange parameters will return to normal within about 15 minutes. Somebody with severe parenchymal lung disease, it can be several hours. So again, somebody with bad COPD, bad ILD, you're probably going to be watching them a little bit longer in the recovery day than otherwise. They usually get back to normal, but it can take a little while. Hemodynamics, through adrenergic stimulation, you get increases in heart rate, pulmonary artery pressure. This is due to mechanical irritation, anxiety in somebody who's on their general, and then the hypoxemia and hypercapnia can help drive that to some degree as well. You can have up to a 50% increase in cardiac output. This is important in your post-MI patients. Again, that increase in cardiac output is just myocardial strain in somebody who still maybe has a potential for ischemia there. So you need to be cautious in patients who've had a recent cardiac event. And again, these parameters return to baseline within about 15 minutes after completing the procedure. Cerebral hemodynamics, this question always comes up in the neuro ICU. And yes, you will increase intracranial pressure. Now, Dr. Peerless, who was at the VA, I don't know if he still is, he did this study when he was over at Metro, but they found that the increase in ICP is about a little over 100% during bronchoscopy in patients who had monitors in. However, the cerebral perfusion pressure didn't change because they had concomitant increases in MAP. So there was no adverse effect on neurologic outcomes. So is it safe to do in patients with ICP problems? It is, but again, it's something you want to be aware of. So complications, and Dr. Med is very quotable. I'm not afraid of complications, I'm afraid of the non-diagnostic procedure. Complications will happen. Doing procedures is always balancing that risk and benefit. If I really need the answer, I'm going to have to accept potential for complications. It's going to happen. Medication, I think we're running short on time here, probably overtime. So we'll run through this, and then the radiographic stuff you guys can look at. It's really more for reference anyway. This is one of my favorite pictures and quotes. Giamma in the 1960s says that 5 minutes of conversation with a physician can be as effective as 5 milligrams of Valium. So this is what you have to strive for. Try to replace your benzos with your soothing voice. But this is there's Dr. Killian standing there in the background as one of his assistants performs a rigid bronchoscopy. This patient is awake. They are probably topicalized, but they are awake. And maybe my favorite part of this is while they're doing this on this awake guy, he's actually holding the bowl to catch his own drool as they do this. So you can do a lot without really much in the way of anesthesia, so keep that in mind. Again, these are more for moderate sedation, which we're moving away from, but in general, what we're using are a combination of benzos. Versed are drug of choice just because it's onset, onset and off, comes off fairly quickly. Same with fentanyl. When I started training, we were using a lot of morphine with occasionally some Demerol, but now because of fentanyl's quick onset and it comes off quickly, we tend to use that. Anticholinergics, we've really moved away from. They don't do a great job of preventing secretions, and a lot of times cause more complications with tachycardia and whatnot. The equipment, get to know your equipment, talk to the tech, see how they set it up. If you know how to use it, it makes everything easier for you. And then intubate. Who's doing procedures right now at the VA? All right, you're not. This is your first time now. All right. Again, different ways to get in: transnasal, transoral. Transoral is difficult. And one, you always want to use a bite block. The last thing you want to do is have your patient bite down on your scope or your finger. But getting through it seems like it would be simple, but the bronchoscope is fairly flimsy, and getting through the mouth, especially in an awake patient with the tongue moving stuff around. The nose is actually much easier because it holds it in place and drops you out right above the upper glottis. So, in general, when you're doing the moderate, I far prefer the nasal route. Plus, you tend to avoid some of the gag centers in the back of the throat that you don't. So you end up using a lot more topical when you go the oral route, I find. You've seen some of these views, laryngeal anatomy, radiographic anatomy for the different different lobes based on chest X-ray. Again, you guys can look at all this later, CT correlation, bronchial nomenclature. Get to know both the names and the numbers. 10 segments on the right, 8 on the left. And these are the airways, this label you guys will notice later. And then driving the bronchoscope. I think, we talk about it driving, but in reality, it's really more like flying. You're moving in a three-dimensional space. Your car hopefully doesn't go up and down, depending on how you drive. But, it's not supposed to. Whereas the bronchoscope moves in all directions, in every plane. Now, your control of it is very limited. All you have is a thumbstick that pitches it up and down, and you have to roll right and left. But think about it more as flying, I think. You're going to sort of pitch and roll is how you're going to control it. And so I've seen too many trainees trying to basically drive it like a car and think that you can just make a sharp turn. In reality, what you want to do is, kind of bank into it and sort of swing it wide and then, sort of roll and go in. And so think about it more like flying. I think that'll help you get control. You'll hear over and over again, center, get off the wall, those sorts of things. And when you're doing these procedures, and we talk about all of this first, because everything else we do, all of the sampling techniques, any of the therapeutic techniques, all of that is all predicated on how you drive the scope. That's really step one. If you can't control the scope, if you can't keep it steady, if you can't get it where you want it to, you're not going to be able to do any of the other things that are then layered on top of it. So focus on learning to control the scope and drive it, and and then we'll as you get experience with that, we'll layer on all of the other skills. And then we'll talk about this. Resources. Bronchoscopy.org has some cool stuff. They've got a lot of videos, schematics, and other things. And then there's actually some apps. Olympus is a couple things you can download. They tend to work a little bit better on like an iPad, but they can be downloaded to your phone. And then this PalmX and AirwayX are sort of simulator things that are free to download that you can use on your phone and sort of virtually do some bronchoscopy. So things to play with. And I know we're late, so if you can stick around, if you want to ask questions, please do. Otherwise, you're good. And we're always around if you need something. Has Dr. DeFelice started yet?
Not yet.
Not yet.
Okay.
So that'll be good, because I think when he starts over there, there's going to be